Welcome back, Focus Learners. I am absolutely thrilled to have you here for today's explainer. Listen, if you've ever looked at the American Medical Association's EM or Evaluation and Management Guidelines and felt like you were trying to decipher some ancient, untranslated manuscript, you are definitely not alone. It's a lot. But today, we are changing that. We're taking those dense, incredibly complex AMA guidelines and translating them into actionable, crystal clear clinical confidence. By the time we wrap up this explainer, you're going to have a rock-solid grasp of how to code accurately, how to reflect your actual clinical work, and most importantly, how to protect your hard-earned revenue from audits. Okay, let's dive right into this. Here is our roadmap for today. First, we'll cover the new EMM guidelines. Second, coding by time thresholds. Third, medical decision-making basics. Fourth, telehealth and virtual care. Fifth, modifier 25 and necessity. And finally, number 6, compliance and audit readiness. Section 1, the new EM guidelines, simplifying coding rules. Before we get into the weeds, we have to acknowledge the historical struggles that medical coders and providers faced for literally decades before these recent structural shifts. Honestly, it used to be a complete nightmare of bean counting bullet points. Pre-2023, you were forced to weigh 3 separate tedious components: history, examination, and medical decision-making. And what did that lead to? Mostly just bloated, cloned notes just to hit arbitrary criteria. But under the 2023 and beyond AMA guidelines, it is elegantly simplified. For office and outpatient services, your code level is now driven by just one of 2 things: medical decision-making or total time. This is a massive win, guys, because coding now directly rewards the actual cognitive and clinical work you do rather than your ability to endlessly click boxes in an EHR. Section 2, coding by time thresholds. Total time matters. Let's talk time. There are specific time brackets for both new and established patients. Just as an example, a level 4 established patient visit, that's a 99214, requires somewhere between 30 to 39 minutes. But here is the critical takeaway you cannot miss. Under the new rules, total time includes both face-to-face and non-face-to-face work performed by the provider on the exact same date of the encounter. That means reviewing prior labs before the patient even arrives, the actual counseling during the visit, and the documentation you finish up later that evening. As long as it's the same day, it all adds up. But what happens when your time goes beyond those maximums? Well, that's where prolonged services come in, and you need to be careful here because there is a critical divergence based on the payer. For commercial payers, you're going to use CPT code 99417, which is a neat little add-on code applied for every additional 15 minutes. But for Medicare, you must use HCPCS code G2212. These are totally distinct billing code sets, and Medicare is incredibly strict. The clock for G2212 only starts ticking after you have exceeded the absolute maximum time of the base code range. So for a 99215, you have to hit 54 minutes before that clock starts. Mixing these up is an instant denial for sure, so keep this distinction locked in your memory. Section 3, Medical Decision-Making Basics, MDM Complexity Levels. Now, if you aren't billing by time, you're using medical decision-making, or MDM, and this brilliantly illustrates how clinical reality maps directly to E&M levels. If you have a self-limited problem, say a mild cold, you're looking at straightforward complexity. That's a 99212. A patient with controlled hypertension, that's low complexity, 99213. But let's say a patient comes in with an acute exacerbation of COPD, or maybe a diabetes case that requires medication adjustments. Now you elevate to a 99214 for moderate complexity. Finally, high complexity, the 99215, is reserved for severe situations. Think acute congestive heart failure requiring a multi-system review and urgent intervention. The bottom line, your diagnosis and your clinical plan absolutely must justify the complexity level you choose. Section 4, Telehealth and Virtual Care, Coding Digital Encounters. Let's shift gears to virtual care, because for distinct virtual encounters, specific codes and modifiers are required. If you're doing a synchronous audio and video visit, you generally just use your standard EM codes, 99202 through 99215, but you must append modifier 95 to indicate you used audio-video tech. Now, we've all been there. The video fails, right? If you switch to an audio-only telephone call, you shift entirely to codes 99441 through 99443, and you use modifier 93. We also have separate codes for asynchronous store and forward image reviews, like a patient sending a photo of a rash, and brief 5 to 10 minute virtual check-ins using G2012. But of course, with new technology comes new compliance traps, and I want you to actively avoid these. The biggest red flag?
using an in-person place of service code, like POS 11 for a standard office, for a telehealth encounter. That literally tells the payer the patient was physically in your office when they definitely weren't. Other massive pitfalls include missing those 95 or 93 modifiers we just talked about, billing new patient codes without documenting proper digital consent, or trying to build time-based codes without documenting your explicit start and stop times. Avoid these, and your telehealth claims are going to sail right through.
Section 5. Modifier 25 and Necessity. Unbundling EM services. Okay, we really must give this critical modifier its due respect. Modifier 25 is defined as a significant, separately identifiable EM service provided by the same physician on the exact same day of a procedure. You use this to clarify the circumstances of care to prevent inappropriate bundling. See, when you perform a minor procedure, a basic evaluation is already included in that procedure's payment. Modifier 25 tells the payer, hey, wait, I did substantial, extra cognitive work above and beyond the procedure itself, and it's documented right here. So, the crucial point is, how do we actually apply this in the real world? Let's challenge ourselves with a practical scenario. A patient visits for a scheduled hypertension follow-up. While they're there, the provider also evaluates and performs a wart removal, which is CPT 11055. Think about it for a second. How do we code this to ensure we get paid for both the chronic disease management and the procedure? And here is the answer. You build the EM level, let's say it's a 99232 for the hypertension management, but you absolutely must append modifier 25 to it and then build the 1155 separately. Appending modifier 25 to the EM code is literally the only correct way to unbundle the cognitive management of the hypertension from the minor surgical procedure of the wart removal. But listen, all of this coding relies on one unshakable foundation, and that brings us to this CMS quote. Medical necessity isn't just a friendly suggestion, it is a strict federal standard. It dictates that services must be proper and needed for diagnosis or treatment, meaning good medical practice, and absolutely not mainly for the convenience of the provider or the patient. If your clinical documentation doesn't justify exactly why a higher-level EM or a separate procedure was necessary, no magical combination of codes or modifiers is going to save you in an audit. Section 6. Compliance and audit readiness. Protecting your revenue. Let's talk about the non-negotiable best practices for compliance. First off, you must ensure medical necessity for every single E&M code, period. You also have to avoid modifier stacking. Don't just throw multiple modifiers on a claim hoping one sticks without explicit clinical justification. Keeping clear, transparent audit trails for every modifier use is vital. Why? Because every payer, whether it's CMS, Aetna, UHC, handles modifiers just a little bit differently. Regular quality assurance audits on high-risk modifiers like 25, 59, and 57 aren't just good ideas. They are essential survival mechanisms for your practice. Before we finish up, let's do a rapid-fire rundown of the most frequent documentation failures that inevitably lead to claim denials. Number 1, using time-based codes when your medical decision-making documentation was already sufficient for a higher level. You're leaving money on the table. Number 2, improperly counting clinical staff or nurse time toward the provider's total time. Remember, provider time is provider time only. Number 3, omitting the total time documentation in the actual note. And finally, the most notorious trap of them all, cloning notes. Copying and pasting previous visit notes without individualizing today's encounter is a massive, flashing red flag for auditors. So, I want to leave you with this provocative thought to chew on as you go back to your day. Are your clinical notes truly audit-ready for the simplified yet heavily scrutinized 2023 and beyond EM guidelines? Seriously, take a hard look at a documentation today and make sure it reflects the excellent care you are actually providing. Thank you so much for joining me for this explainer. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.